Hi, my name is Monica, and my change project is regarding PMAD. What is PMAD? PMAD stands for Perinatal Mood and Anxiety Disorders. It encompasses a range of mental illness disorders, including depression, anxiety, obsessive compulsive disorder, bipolar disorder, and PTSD that occur during pregnancy and up to 2 years postpartum. It also includes postpartum psychosis. PMADs are the leading complication of childbirth and one of the most often overlooked, affecting 1 in 7 women. So my question is, will screening pregnant women upon admission help us identify those at risk sooner, or that we can early intervene, educate, and refer them appropriately before being discharged? Currently, we are screening postpartum women 12 to 24 hours after birth using the Edinburgh Postnatal Depression Scale. It is a 10-item questionnaire. It is used as an indicator of the risk of depression and anxiety, but is not a diagnostic tool. It is a screening tool so that it can help us identify women who need follow-up care, mental health assessment, and referrals for further assessments. Women scoring 10 or higher is considered at risk for depression and/or anxiety. Women scoring greater than or equal to 13 will have a positive screen. So what's the problem? Well, in non-complicated pregnancies and deliveries, mothers often are discharged within 24 hours. Now, with C-sections, some moms are there for 3 days, and those that are positive for GBS and was not treated during labor will be there for 2. Sometimes these new moms have not even seen a social worker before being discharged if their pregnancies were not complicated. And sometimes these new moms will have a social consult done before they were even screened with the screening tool. And so they would be sent home without being treated appropriately. Within the last 6 months, our records show that 5 mothers were discharged home with a positive EPDS that were missed. Later misdiagnosis of PMADs in women can delay treatment and pose adverse effects on mothers, their children, family, and community around them. Literature reviews. Multiple studies have shown that screening for PMAD is not a standard practice for our obstetricians. Although many hospitals have been screening patients using also the Edinburgh Postnatal Depression Scale as recommended, many obstetricians continue to just use clinical evaluation. Less than 5% of patients choose to seek help from their OB. And this is because the public believes that mental health care is outside of an OB scope of practice. Knowledge of perinatal mental health was the main factor associated with different treatment preferences. Many moms do not know that this is part of perinatal care. Women with perinatal depression are at higher risk for postpartum depression. Implementing a universal screening and providing education and enhancing the awareness of mental health across the perinatal period is an effective strategy for improving treatment rates. Of course, contrary to what clinicians believe, there is a high acceptability of routine prenatal and postnatal health, mental health screening. In one of the reviews, social demographic risk factors have shown to increase the prevalence and incidence of prevalent postpartum depressive symptoms. So antenatal depression should be evaluated in pregnant women. 15 to 25% of women experience depression or anxiety during pregnancy or in the postpartum period. Perinatal depression can affect any woman regardless of ethnicity, age, race, or income level. Only 40% of these women with PMAD actually seek treatment. The prevalence of postpartum psychosis is only 1 every 1,000 births. Prevalence of antenatal depression is 7% to 20%. Some of these risk factors for PMAD is lack of knowledge, lack of support, stressful events such as death in the family, financial hardships, divorce, and lack of support from families and friends, lack of resources, lack of care. Past delivery traumas can be a risk factor if a mom has had a traumatic delivery. History or current use of drug and alcohol, history or current physical, emotional, or sexual abuse, history of postpartum depression or anxiety in the past, and then history of miscarriages or stillborns. Vulnerable populations include teens, single mothers, military women, low-income women, socially isolated women, recent immigrants, and those women with complicated and high-risk pregnancies. Barriers to access care. Many women are afraid of the stigma of mental health and psychiatric illness. There's a lack of timely intervention with knowledgeable providers, such as routine screenings during the antenatal period. Aversions to taking medication. Some moms are afraid of taking medication, and this is mainly due to lack of knowledge. Negative feedback from support systems, and then lack of resources. The APDS score should never override clinical judgment. So what is the purpose for this change? And what I want to do is to increase the identification of PMAD in pregnant and postpartum women while in the hospital to decrease the prevalence of maternal morbidity and mortality, as well as adverse effects on their children and family. In our facility, we screen women after delivery. Studies have shown that the importance of screening women at least once during pregnancy, postpartum, and 6 weeks after delivery. I truly believe that early identification and early intervention will lead to proper management. Our target audience would be for really the maternal child health nurses, labor and delivery, NICU, and postpartum. Most of the NICUs and postpartum RNs are aware of this scale, but I think that it would be something new for the labor and delivery nurses. So interventions, what and how? What I'd want to do is to implement the routine screening using the Edinburgh Postnatal Depression Screen upon admission. Currently we are screening and we do have a protocol in place. I just wanted to try and see if we screen our mothers sooner, would that give us more time to intervene and not miss our mothers who need help. What I initially would do is talk and work with our manager and physicians. The manager is who will help us in the implementation process. Physicians are important in the process because they too need to know the importance of screening women, even antenatally. They are the primary providers for these women, and they will also be the one following up with them 6 to 8 weeks after delivery. They will be notified when the patient has a at-risk or a positive screen. It is important that we need to educate and teach our nurses on the risk factors of PMAD. And so here I included on my slide that I would provide the nurses a little flyer or a little pamphlet that goes over the characteristics and risk factors that they need to look for. And per our protocol, if any moms need a social consult, we can initiate that, and social consult will follow up with them. But because they are flagged as having any risk factors, one of our important things is that we need to follow up with that and make sure that these moms get what they need. One of the things that they do also need to consider is their cultural cultural considerations. At the birth of a child, there's usually, it's usually a time of joy for the mother and the family. But any type of, once a mom becomes depressed, that could come with negative consequences. PMAD is complex and challenging, and that can often take women and families by surprises. Beliefs and expectations from different cultures can place intense pressure for women to hide these symptoms. So cultures may actually serve as a barrier to those with symptoms to seek help. So they'd have to be aware of that also. I would also go over the Edinburgh Postnatal Depression Scale. We do use the scale postpartum, but the labor and delivery nurses will have to be familiar, and so we'll go over how to scale this. Evaluation and outcomes. Scores and interventions with date and time will be charted in our computer system called Cerner as usual. We will be able to filter out those that are missed. The data will be collected over a 6-month period, and the data that is collected will be evaluated, and I would compare that to 6 months prior to see if there's any improvement in providing appropriate treatment to those who are tested positive. I hope that through my findings that the hospital would decide to change our screening process and that the physicians would see the need for this. It's through this research that I was able to find within the last 6 months that 5 of them were missed. And so my goal is to have no patients with a positive screen on the EPDS to be discharged without the appropriate treatment or referral. If effective, pregnant women will be screened during admission, and so then the plan of care would be adjusted to patients, so then that way we would educate, refer, support, and follow up as necessary. Implications for nursing practice. The change is a multidisciplinary action that involves the collaboration of everyone involved in the patient's care. Literature have shown that there is a lack of antepartum screening and interventions. So interventions during pregnancy may prevent the development and progression of antenatal depression to postpartum depression. We know that discharge planning always begins with a patient's admission and should continue during the patient's stay through discharge. This proactive approach thus would make it appropriate to screen women as they are arriving so that we can meet our patients' needs. We are advocates for our patients' care. Any questions? Thank you for watching.